Magill. Thank you for that introduction, Jason, and thank you everyone for coming. So this is the North Valley ER, AKA the best little ER in the whole wide world, as we like to say. And so my goal is to give you guys a look behind the curtain, so to say. So what I'm going to do is present to really actually create the environment of the ER for you. I'm going to be presenting 4 cases at the same time, somewhat simultaneously, but also a little bit staggered, so you really get an idea of how the flow in the emergency department works. Everybody, just to make it kind of able to keep up, because it does get a little chaotic, all the patients have their own little icons, and I will kind of go room to room, so you'll be coming with me as we basically go through the ER and evaluate and diagnose and treat patients. Audience participation, so if I start talking a million miles a minute, there's a good chance that will happen. Somebody just raise your hand or something, cough aggressively. So here we go. So basically, we're coming on shift and you're all gonna come with me. So we're gonna start off with room 2. So we walk into room 2 to see our first patient of the day. We've had a couple sips of coffee, and this is the patient identifier. It's a pregnancy test. And this is a 34-year-old female who's coming in with vaginal spotting and abdominal cramping. She says maybe she's 4 to 5 weeks pregnant based on her last cycle. It's her first pregnancy. She doesn't have an appointment with OB for 2 weeks, but these symptoms started last night, and she really didn't feel like it could wait. So every patient, just as a side note, will have vital signs and kind of pertinent exam findings. Anything super abnormal will be, or abnormal, not super abnormal, will be in red. So this patient, you look at her vital signs, it looks okay. Her heart rate's a little fast. Sometimes that can be a natural response when you're in the ER, because it's exciting. And other times it tells us that maybe there's something else kind of going on beneath the surface that we need to be really looking for. And on her exam, she's pretty tender in her lower abdomen. So at this point, 3 things are in my mind, from most serious to least serious: an ectopic pregnancy, or a pregnancy that's implanted in the wrong place or outside of the uterus, a potential miscarriage, or some vaginal spotting in early pregnancy. So in order to evaluate those, what we have to do is get an IV established, send some blood work, including a serum pregnancy-like hormone level, which will kind of help guide us in our evaluation. And then we're gonna go ahead and grab an ultrasound to see if we can identify a pregnancy within the uterus. So I come back out to my desk, this is my desk, and I go ahead and put those orders in. And at the same time, EMS is coming in with another patient. They're bringing us gifts, and this is a 65-year-old gentleman who's coming in with cough and shortness of breath. These symptoms have been progressive over the last week. He's coughing up sputum, yellow-green mucus, he's having sweats. EMS was nice enough to put an IV in, and then go ahead and give him an albuterol nebulizer to try and open up some of his lungs, which they felt like were pretty irritated. So when I'm looking at this gentleman, you see all the red. Not good. So he's got a fever, his heart rate's up, he's breathing really fast, and his oxygen is pretty low. And you look at him and he's sitting on the bed and he's kind of working, and he can talk to you, but he's not really looking very comfortable. His lungs sound like junk. Can't really hear a whole lot going on in there. So as Dr. Cohen mentioned, this is a great time for us to talk about sepsis, because this gentleman in our ER would trigger basically a sepsis protocol to be initiated. And we'll kind of go into a little more detail on that in a minute. But in our ER, we have this lovely purple form that all of my nurses have come to know and love, which really clearly outlines what are the priorities in these patients. So this gentleman is gonna go ahead and get a second IV started. We're gonna send some blood work, including blood cultures and a blood test called a lactate, which is a marker of kind of perfusion at the cellular level, and it's used in sepsis, it's used in all kinds of medical diagnoses to kind of determine severity. We're gonna grab an EKG, a chest x-ray, we're gonna start some fluids, and then this gentleman's gonna get put on BiPAP, which is a way to kind of non-invasively support his breathing. It kind of forcefully blows some air into the lungs, and we're gonna do some medication through that to try to open up his airways to really help his work of breathing. So I communicate all that to the nurse. I'm gonna go outside and click a bunch of buttons. You see, I'm just walking around clicking buttons. The nurses are really carrying the bulk of the weight. And I come back out. So here's our ED tracker board at this point. We've got room 2 over here. Checking in on her. Her lab test comes back and her serum pregnancy hormone is at 6,500. All that tells me is that I should, at that level, expect to see a pregnancy in the uterus on the ultrasound. That's all I'm using that for. And right now they're doing her ultrasound, so we're gonna keep an eye on that. And then in the meantime, we get a point of care lactate back on this gentleman that's 3.5. So when we're talking about sepsis, it is a spectrum, similar to politics, I guess. But what you have is on this side, you have the starting point, which is where you get what's called systemic inflammatory response. And that can be multiple kind of non-specific things, like a temperature that's either low or high, a heart rate that's fast, a respiratory rate that's fast, oxygen saturations that are low, a white blood cell count that on blood work is either high or low. And all that means is that your body is reacting to something. So it does not have to be an infection. Your respiratory rate goes up when you're upset, your heart rate goes up when you're in pain. All kinds of things can trigger. It just means there's something in the body that's causing a response. When you take those criteria and people meet certain criteria and you then add a source of infection, whether it's viral or bacterial, you have sepsis. That doesn't necessarily mean that people are critically ill. 20-year-olds can walk around and meet sepsis criteria and look phenomenal, and they can also look really junky. So that, for us, is just kind of boxes that are checked. Where we really get on high alert in the ER is when people cross the midline into that kind of severe sepsis, and then finally septic shock territory. And what we're looking for at that point is they're starting to show us signs that internally their organs and their body are not compensating well for whatever process is going on. And then, so for this gentleman, his lactate is 3.5, so under 2 is considered normal. Between 2 and 4 puts you in the severe sepsis category, meaning there's signs of strain internally while you're trying to battle whatever process is going on. And a lactate greater than 4 puts you into shock territory, means that you're compensating but you are failing. So this gentleman gets severe sepsis protocol, and now we just need to identify his source, which is right here. So common things being common, our most common source of sepsis in people over a certain age, don't take that the wrong way, anybody, are pneumonias and urinary tract infections. So this gentleman has a lovely bilateral pneumonia. The left side is really a lot worse, and then you see this, it's like schmutzy over here. So he's kind of cooking a little pneumonia on both sides, but especially this side. And so then I go and I get out this lovely antibiotogram that our pharmacy and Dr. Jaden, our infectious disease specialist in the Valley, were kind enough to develop for us. And what this does is it ensures that we are using sensitivities from bacteria in the Valley to make sure we are appropriately covering our patients without over-covering and contributing to antibiotic resistance. So this is lovely. So I would just say, oh, this guy's got severe sepsis from pneumonia. It's right there, it tells me what to do. I put the order in, click, and then at this point, I'm pretty sure this gentleman is coming into the hospital, so I'm gonna call Dr. Cohen or one of his colleagues to come help me out. So I've kind of got that plan in my head, and I'm made those calls, and another patient is coming in. So this is the far side of the ER. I couldn't carry 4 poles, I'm sorry. And now we have an adorable 8-year-old girl that was doing gymnastics at home and kind of landed wrong, and she hurt her wrist. And mom gave her some Motrin, but it's been about an hour, and she's still really not moving it well. So you got this adorable girl, her vitals look great, her wrist is a little swollen, she's got some tenderness, she's not wanting to move it very well. And so for her, the workup is pretty simple. We're just basically gonna put some ice on it, grab an x-ray, and then tell her not to eat or drink anything in case we need to do a sedation and kind of click on it a little bit while she's in the ER. So I'm coming back out to the desk, gonna click some more buttons, put in some orders. And at this point, just touch base on everybody. So back in room 2, our lovely 34-year-old female with the vaginal spotting and the positive pregnancy test, the ultrasound is done and they do not see a pregnancy in her uterus, but they do see a ton of free fluid in her abdomen. And immediately, sirens are going off in my head that this patient has an ectopic pregnancy. And in this case, with a lot of free fluid on exam and a fast heart rate, kind of tells us that she's likely bleeding internally from this. So we immediately call OBGYN on call. This is a surgical emergency in this particular patient. And so she gets whisked away to the OR crew, anesthesia, everybody comes. And then she's gonna go over here and do great. And then at the same time, we have our gentleman over here with the pneumonia. He's getting his antibiotics, he's getting his fluids, he's on BiPAP. The hospitalist is at bedside, kind of taking a look at him, getting their plan together for admission. And x-ray has just come out from our 8-year-old female's room. And this is what her x-ray looks like. And she's got a super simple, really lovely Just little distal radius buccal fracture. It's really cute. And it's not gonna really need anything but a splint and some time, and she's gonna heal like a starfish. So she's gonna get put in a splint and a sling. This is her splint and sling. And then she's gonna go to orthopedics. We do have stuffed animals, by the way. That's a real thing that happens in the ER there. So she's gonna leave too. So we're gonna let her go. And so now we're like, oh, great. We just got our gentleman over here with the severe sepsis. Hospital says at bedside, everything's going good. I might get some breakfast. But they come out and we're talking and looking at the patient. He's still working pretty hard. And his chest x-ray, you guys saw it, it looks horrible. He's been sick for a week. So we kind of, knowing kind of what's coming is this gentleman is showing us signs that he's in early respiratory failure. He's already needing some non-invasive ventilatory support. So there's a pretty good chance that he's probably gonna need ventilatory support at some point. So sometimes in these patients where we recognize that their body is already under significant strain from this infection, we talk about electively putting them on a ventilator for ventilatory support before it becomes an emergency. And in this case, everybody felt like that was a great idea, including the patient. And so we decided to prepare for that. So we're gonna move him into a little more spacious room, have respiratory therapy come down, get some sedation ready, probably put a central line in, which we'll talk about in a minute. So nursing is gonna kind of get him moved. We're gonna prepare all that. And in the meantime, I'm gonna go see this new patient that just came in to room 5. And in room 5, we have a 55-year-old guy who comes in 45 minutes of kind of pain right here, vomiting. He's got a history of high blood pressure. He's not sure if he ate something. It just feels really bad, really a lot of pressure in that area, but isn't really having any diarrhea, no other belly kind of problems. And looking at him, his heart rate's a little fast again. It's exciting. Blood pressure is up a little bit. And he just looks like sweaty, but his belly's nice and soft. And you're kind of like, this is the area I like to call the chabdomen. It's like no man's land in between your chest and your abdomen. And so this guy is unfortunately going to get kind of a workup for both, but so we're immediately going to say, okay, the most important thing with this is we need to get an EKG within 10 minutes of arrival, which is our goal for all patients who come in the door with chest pain. We're going to grab some blood work as well to check, liver, pancreas, all the good things that live up here. We're going to get him some nausea meds, see if he can tolerate some aspirin, get an IV in him, and get that going. So you come back to the desk, and then the respiratory therapist comes down, and within 10 minutes, they hand you this. And then I get chest pain, because this gentleman is having a heart attack. And so in the ER, we're primarily dealing with 2 kinds of heart attacks. The kind where I look at this and I say, oh, snap. And the kind where this looks okay, but his blood tells me that his heart muscle is angry. So this is the kind where we immediately recognize, so ideally, when you have an EKG, I'm gonna use this laser pointer here, you should be able to draw a straight line kind of all the way through, and all these nice little flat lines, especially this one, should kind of touch this line at some point. But look over here. If you draw a line, my hand is shaking. This is a horrible line, I apologize. That doesn't touch it, and that is really elevated. And so that is what we call an ST segment elevation myocardial infarction. The other kind is called an NSTEMI, non-ST segment elevation myocardial. It's creative myocardial infarction. So this is the kind where we have 90 minutes from when this man walks in the door to get him down to Kalispell, get him on the table, and have interventional cardiology, potentially putting a balloon in his vessel to save that heart muscle. So at this point, we come out, we let the nurse know we're activating our STEMI protocol. It's on pink paper. And this basically outlines all the things that he needs to have. So we're initiating all these medications. It's the Mission Lifeline standard of care that we do across the state of Montana. Kalispell does it, we do it. Make sure everybody gets what they need before they get on that table. So while nursing is doing this, it contains all of the orders and everything. I'm making 8,000 phone calls to talk to the cardiologist, talk to Kalispell, get an ambulance coming, doing a bunch of paperwork, so we can get this man from the time he sat down in that bed on the road in less than 30 minutes. And we do that pretty quickly. So that's his thing. So he's gonna go to Kalispell because we can't fix that here. But secretly, I will tell you our times to get people on the cath lab table are a little bit quicker than theirs, and how we do that from coming from outside, I don't know, but it's just in their self-plug. So I feel good about that. Now I gotta go over here for my severe sepsis gentleman who's actually maintaining pretty well and doing okay. And we're gonna go ahead and do what we talked about doing. So I brought this is what an endotracheal tube looks like. We sedate him and kind of put it down there, and that's gonna that's going to breathe for him on a lovely machine so he can kind of rest his respiratory effort. And then we are going to use an ultrasound and put this little lovely long IV in his internal jugular vein in his neck. And the reason we do that is because it allows us really good central venous access to administer medications, fluids, to draw blood, to monitor central venous pressure. It's a pretty useful tool in critically ill patients. We also put them in the groin, but with this type of patient, if we're able to, we really like to put them in the neck. And all of our docs can do those under ultrasound guidance, so it's a pretty safe procedure for patients. So he's gonna have those things done. We're gonna get a chest x-ray to confirm them, and then he's gonna go over to the SCU. He's gonna just go away. I put too much stuff on this one. And he's gonna get better with the great hospitalist care, and then this gentleman is on his way to Kalispell to go to the cath lab. And so, that's it. I'm kind of tired, but the day is just getting started. We've still got a lot of time left. So just to kind of review, we had a patient with an ectopic pregnancy that was a surgical emergency. We had a gentleman with severe sepsis from pneumonia who had respiratory failure and was electively intubated. We had a lovely, adorable kid with a distal radius buccal fracture, and then we had a gentleman having a heart attack. So this is just a small sampling, and if it gives you any idea of, we're constantly seeing different patient ages, different comorbidities, different presentations, we're doing different workups, we're evaluating multiple different things at the same time. So this is like a lovely word collage of all the potential things that we can see in the ER. So we can see trauma, we can see strokes, we can see mental health issues, substance abuse issues, complications related to diabetes, things that people stick in their butts that shouldn't be there, all kinds of things. And then we call Dr. Means, and he helps us out, begrudgingly. But it's kind of like we're a jack of all trades, and the ER can go from 0 to 60 in 3 seconds, and people can come in cardiac arrest, and people can come in because their throat is sore. So that's a crazy thing, but it's also a really fun environment to work. This is my team. So as Dr. Cohen said, all of our docs are ER trained, ER boarded. And then we have some of our awesome nursing staff. And honestly, we're lucky. We have great respiratory therapists, we have great lab techs, we have great radiology techs, we have great consultants, and it all comes together so that people really get great care in the North Valley ER. And coming from 2 large academic centers, which is where I worked from before I came here, I am really proud of the care that we provide. And I like to think that big or small, no matter what your emergency is, day or night, that our team will be there and we will be ready and your care will be phenomenal.